A little bit about the Bipartisan Policy Center. We're based in Washington. It was actually formed by a number of the former Senate Majority Leaders, bipartisan, Democrats and Republicans, in about 2007. Its roots were in energy. We've recently taken on healthcare in the last 3 years or so. Actually had a report around what should be in healthcare reform that was released in a bipartisan manner back in June 2009, and which syncs up a lot with actually some of the elements that you're seeing today in the Affordable Care Act. About a year and a half ago, we launched the Health IT Initiative, and I have the pleasure of chairing that initiative. And what do we do? Laura talked a little bit about what we did. Probably, we issue reports, but think tanks issue a lot of reports, right? And sometimes they sit on the shelf. Ours sits on the shelf, but we try to pick those areas that have been especially thorny, that there hasn't been agreement, a gap, we think, whether it's in action or leadership, areas that really need an extra push, and we bring people together, including Republicans and Democrats, on an issue. And health IT was an issue that we thought needed some further review and discussion, public-private dialogue, in addition to all the really good work that HHS is doing. And in fact, released a report. I'm going to talk to you a little bit about it. There are recommendations in the slide, but then talk about some of the things that are going on now as well that aren't in the slide. We released a report, had a task force, Senators Daschle and Frist co-chaired this task force, and back in January said, okay, as a country, a lot of the health plans, private sector organizations, and the federal government through CMMI are moving forward all these wonderful delivery system and payment reforms that are designed to address some of the big issues we're experiencing right now around the need for more cost containment, the need for improved quality across the country. And so we looked at what's needed within high-performing organizations as well as these new models of care, and then we stacked that up against how health IT can help and how do the investments that we're making as a country, whether it's the $30 billion in taxpayer money or all of the investment exceeds that's happening within hospitals and physician practices and tech companies today, and how do we line up. And so I'm going to spend maybe about 8 minutes on that, talk a little bit about some of the work that we're doing now before we dive into Q&A. So this is probably old news to you, but it's funny, having been entrenched, like many of you, around this exchange effort. Do you remember, gosh, back in 2001 and 2002, I spent a lot of time in this world, and sometimes it's easy to get engaged in it and talk about what's happening and what's getting in our way. But really, in looking at our report, and you'll see this, I think things that are old news to us and pretty boring and we don't care very much about anymore, I was amazed to see, even back in January when we released this report, there were many folks, many policymakers, many folks on the Hill, many employers, many health plans, many folks that didn't realize with the big investments that were being made that we were really falling short in the way of interoperability and health information exchange. So we put a big laser beam on that issue, both in the national media and with a number of folks that could try to drive change and to sort of light a fire on it. And I think that a lot of progress is being made, but I think, as you well know, a lot more needs to be made in order to move this work forward. So what did we do? So we started with what constitutes high performance in healthcare. What health, almost a project, if you will. What health IT capabilities do we need, and how do those stack up with what we have? We interviewed 40 high-performing organizations. We did a ton of research. And in the interest of time, because I want to leave enough time for Q&A, I'll go through this pretty quickly. We'll put this on the USB that you have, so it's all in there. No surprises here. When we talk to high-performing organizations across the country, organization-wide focus on the patient, Not always the case in organizations across our country, but a common theme amongst high-performing provider organizations. Strong leadership at the top, also strong clinical leadership at the top. Again, you don't always see that, but that was a common theme across the organizations we spoke to. Of course, access to information across the care team, and we talk about that a lot. Doesn't happen very much today, though, even in our nation's highest performing health systems. A lot of it is in paper. A lot of them have trouble getting information to flow between hospital and primary care, between primary care and specialists. Not happening yet today, but very much needed, and they make do with what they're able to accomplish with paper, fax, and the like. Timely access to care, of course. Emphasis on prevention, wellness, and healthy behaviors. I know that's been a topic of discussion around some unfortunate cutting that's going on. And then number 6, accountability, alignment of incentives, and payment reform. So pretty standard stuff, but wanted to start there as opposed to starting with health IT. So boiling it down in the interest of time, it's a long report, but we talk about what we need. Of course, access to information, and this aligns a lot. I know Claudia is here, Claudia Williams with HHS. This aligns a lot with the meaningful use framework that was put in place by HHS, CMS, and ONC. Clinical decision support at the point, at the point of care, virtual care, and the ability to analyze and aggregate data. And I know that the how around all of these things and what you do in stage 1, if you're talking about meaningful use, stage 1 versus stage 2 and stage 3 are really important, and there's been a lot of discussion around the pace at which we can move forward on some of these issues, not to mention this last one. This one's been tough. Lots of dialogue, push and pull amongst wanting to give patients the ability to download their information and providers and clinicians wanting to make that happen, but struggling given with the way the infrastructure works today. So those were the capabilities. I'm going to spend a couple of minutes on our findings and recommendations, and then really hone in on some issues that are in debate right now. So, gaps and barriers. No surprises here. I think surprises for folks that are outside of this room that don't follow health IT and don't listen to the webinars and watching what's happening with meaningful use and proposed rules. Sometimes we're really into it, but the folks, the majority of health policy doesn't think about these issues very much. These are the gaps when it comes to having those health IT capabilities needed for high performance in our healthcare system. So this first one, of course, aligning incentives with better outcomes is going to drive exchange, right? It's going to drive the use of health IT. And we're starting to see that. There's a lot of activity happening across the country around accountable care and the patient-centered medical home, and they're finding, as I mentioned before, that this data doesn't flow very well. So now we're starting, and I think appropriately so, taking that health IT conversation that we used to have by ourselves, remember, and sort of linking it with where the country's going and how we need to address the problems of our healthcare system in a very substantial, practical, on-the-ground way, but we've got some more work to do. I was pleased to see, there have been a lot of hearings on payment and payment models. There was one, what's today? Is today Thursday? Wednesday, was it Tuesday or Wednesday, Energy and Commerce, and then there was one last week where Senate Finance Committee was talking with a number of physician leaders around payment reform. And you know what? The interoperability discussion, did anybody, I'm sure nobody listens to this, but it came up at the end, and they said, well, so tell us, how do EHRs and health IT systems, what do they have to do with payment reform? And I'm not going to I don't have my notes with me, so I won't get this exactly. So if any medical societies are in the room, don't. So what they said was, well, yes, we need interoperability of systems, and we need exchange, and it's not really happening today. It's not really happening today. And the chairman said, well, that's because we need to align incentives. And and I can't remember which, I think it was a primary care society, said, we've got enough incentives, but our vendor systems are not interoperable. And this is a big problem, and we need to address this. And so what we're seeing is in the conversation around payment reform, we're starting to talk about interoperability. And I know in talking with a number of the EHR vendors across the country, they really want that to happen too. And I think the issue is how do we make that happen? And I'm going to talk about that in a couple of minutes. And Laura, you're going to wave your hand at me. How about when I have like 3 minutes left? So aligning incentives. Accelerating exchange. We actually, I would say in our report, half of it was devoted to health information exchange, and we had a long set of recommendations in this area. Of course, building the business case, and I raised some of the issues around payment reform, but also a lot of folks wanted to look beyond wanted to look beyond meaningful use when we talk about exchange. And so when we have a strategy, and necessarily so because the system can only absorb so much change, but what's our long-term strategy for data usage in our country that sort of goes beyond meaningful use? I think a number of the hospital systems and the technology companies, these are capital investments that take a long time, and having a level of certainty, whether it's 2 years out, 3 years out, 5 or 7, around what's going to happen is something that we heard loud and clear. So long-term data strategy that moves beyond adoption and meaningful use. Not clear where that resides if you look at the authority and high tech given to the FACA committees, whether that's a place that it could happen or whether it happens somewhere else. There was some confusion when we released the report on what the path forward for health information exchange was, and we're really excited and pleased with a number of the publications that have come out since then that sort of clarify how all of these pieces fit together, whether it's the direct project or query, push and pull versus push, and how all the projects fit together. So there was some need for the common person around a dummy's guide on how to navigate health information exchange. A couple of other, because this conference is really focused on exchange, so I'm going to spend the most time here. When we interviewed the high-performing organizations and we looked at what was needed for coordinated, patient-centered, accountable models of care, we said a lot of good things about directed exchange and that it was necessary, but it was only a first step in a portfolio, and that we'd need to go beyond that in order to get to the functionality needed for these new delivery system and payment models of care. So that was a big recommendation. And having a glide path that sort of lays out, and I know John Blair's going to talk later about how you move from one step to the other to support transitions of care and then aggregation of data to support quality improvement and new payment models, was an area where folks felt we needed more clarification, strategy, and tactics. Engagement of consumers. So of course, this was the other, when you look at the issues that have been most debated in the proposed rule for stage 2, it was around those health information exchange points, as you well know, as well as the whole section around patient access to information. Well, we came out and said that this was important. It's a critical part. It's not about health IT, it's really about delivering higher quality, more cost-effective care, and had a number of recommendations in that regard. A lot of statements about usefulness and usability and how we could do a better job there, and then lots and lots of statements about, or insights about, helping our nation's hospitals and physician practices get to a place where they've never been. It's been frightening for a number of them, worries about all sorts of things, many of which the pioneers recognize are unfounded, like getting attacked by hundreds and hundreds of emails or issues about liability. Just more education and support for folks as they move forward will be really important. In the interest of time, I'm going to just make a few points here. Laura, we've got 3 minutes. I'll just pick out usability, is a big issue. We had a lot of discussion about the patient safety issues. There's a lot of dialogue going on, as some of you may know, about increasing regulatory action on electronic health record systems. We talked about that, and the need for, through regulatory processes around patient safety, to have a baseline to protect consumers, and then finding a way with those who use systems and those who develop systems to work together to find ways to improve usability that is not necessarily a regulatory approach. The only thing that I would say here, I could have teed up Vicki's presentation around clarity across the board. I think inaction, a lot of it has to do with not being clear, and having more guidance from HHS would help. Or, as we were talking earlier, I know David Kibbe is going to talk about the direct trust, policy framework, just getting to some agreement so there isn't as much risk around moving forward. There is power in numbers in agreeing on some common policies and framework for moving forward. And the only other thing that I would say here, and then I'm going to stop because I know we need to wrap up, is we spent a lot of time on patient matching. We actually issued a report last month that's on your drive. I didn't address it here, but spent a lot of time, worked with Chime and others who were polling hospitals, and actually a number of the hospitals came forward and said, we're worried, with delivery system and payment reforms and with more pressures on exchange, we need to improve the accuracy with which we're matching patients. Did a quick survey, pretty alarming. I mean, there are big safety issues here, upwards of 20% in error rates. 19% of hospitals surveyed had experienced an adverse event in the last year as a result of a mismatch. And so rather than saying, let's go for a unique patient identifier, that's the way to go, we issued a whole range of recommendations around improving the methods by which we match data, getting to agreement on some standards and data attributes, and then exploring, I know a little edgy, but it actually happened in California. Many believe that we're going to need something, whether mandatory or voluntary, some method for improving the accuracy rates. So we've got a lot of discussion around voluntary methods, consumers moving forward in a consumer-mediated way to see if we might improve the level of matching. This is going to become a much bigger issue as we move ahead. And then, in the spirit of stopping, where are we going now? We're drilling down, what are the near-term collaborative actions we can take? Have had a lot of discussion about the tightness of implementation guides and clarity and policy around doing that, and also doing some further work, just wrapping up a survey of practicing clinicians across the country in collaboration with a number of medical societies, and I think the top line, we're going to release it in about a month and a half, is they want exchange to happen. There's certain data types that mean a lot to them, more so than others. You can guess what they are. Lab, medication, imaging results in a set of scenarios. We looked at 3 scenarios: upon hospital discharge, and then the data flow between referring and consulting clinicians. And actually, they'd like it sooner than what folks are willing to give it to them, within 24 hours for the most part. So we're going to need to be creative and do better at that. With that, I'm going to close so we can just move into Q&A. Thanks very much.
We have microphones in the aisles. So for people who have questions, I want to thank you so much, Vicki and Janet, for this. And I think it's really what I want to draw attention to is in the high-performing, the study on the high-performing organizations, one of the things that was very clear was the #1 item is a focus on the needs of the patient. And I think it's very exciting that one of the things we heard here today from our state leadership around health information exchange is so aligned with that, that they are focusing on the needs of the patient in the state of California. And I think California is well aligned to start making a difference and actually making progress. I think the other thing that I heard from both of you is action first. So you've got to make action to figure out how to correct your course. You can't correct your course before you take any action. Anybody with questions, comments?
Hi, thank you so much. Janet, this is a question for you. I wish you had had 2 hours. It was fascinating. I'd like to start from two things you said. One, that in writing one of your many reports, you interviewed the top 40 performing organizations. And of the 6 things they need, the 6th was accountability and alignment of payment incentives. And I'd like to know whether you ever lose sleep at night over the low-performing entities and the fact that they might, along with no question needing leadership and everything like that, that the alignment of payment incentives, especially when it comes to HIE, is an absolute killer and is something we're bumping into all the time, at least in California, as some of us try to extend HIE. A, there is no current incentive for HIE. The entire focus is on EHR. B, the recs don't, from people in the field, don't seem to be addressing it or linking it as the next step at all. And given the safety nets that many of us work with in rural areas as well as just in poor areas, when do you see the linking of those incentives happening and being able to flow down fast enough that we actually can build a business case for the FQHCs, for example? Thank you. And thank you for all you are doing, despite that sounded like a word.
So a couple of points. For me, so we interviewed the high-performing organizations not because we said we thought the focus should be there, but we wanted to be able to identify the capabilities needed, the health IT capabilities needed to drive high performance. But for me, when I think about this, all that we're doing, all that you're engaged in, everyone in this room, around mobilizing information and also EHR adoption is going to enable the rest of the country, even if you're a mom and pop, a small physician practice with, your spouse being the receptionist while you're delivering care, should be able to have access to those same capabilities. So I see a great promise with those that need the help most. In terms of financial incentives, I'm really encouraged by the last several weeks, what I've seen in the last several months among policymakers and folks, sort of the light bulb going on around these are not two siloed focus areas. There's a tremendous amount of focus on new models of care now. You've seen everybody wants to be an ACO, or all the health plans are moving into this. It's not just a government thing, it's private and public sector moving forward, and they're realizing that they need exchange to happen. I think our risk is, and it's already happening, that this happens in silos. So there is a tremendous amount of investment in this country, probably more than in anything else, in getting data to flow for accountable care. But never the twain shall meet. You know what? So that's our risk, and I think we really need to work hard to link these two areas and make one serve the other. I don't know if that helps. It didn't. Thank you.
Anybody else? We are in danger of a first in Redwood MedNet conferences, so we can't have that happen. Thank you, Lori.
Thank you both for the presentation today. And one of the questions that I had was with regard to the alignment of the incentives. Are you seeing in the world that I live in right now with meaningful use and all the criteria, is someone going to take that database of information of all these measures and figure out which ones are working, which ones don't make sense, and you have thousands of doctors now trying to achieve them, and there's simple things like you have to print a piece of paper and give it to a patient to pass one of the measures, which doesn't make any sense in the electronic world. And from a PHI perspective, is someone looking at that either one of you can comment on?
Go ahead.
So really quick, turn it over to Vicki. Actually, that's the part I cut out of my presentation at the end when I ran out of time. But boy, is there energy and passion around this issue. From the health plans, the hospitals, the doctors, the vet, you name it. There isn't anybody that isn't very concerned about this issue. And I think, and I know, Claudia, you're going to talk tomorrow. I don't know if you can talk very much about the national quality strategy. There is work going on around harmonization within the federal government, and it's pretty hard stuff. I mean, there are similar measures which have different specifications that require different processes. It's nuts. I know NQF is looking at this, and I know that the plans very much want to harmonize and even set up some dates for themselves that they put in our report. I think it was June, was it 2013, around getting to harmonization. Vicki?
Yeah, the only thing I would add is, first I'd say ditto, but the other part of it is at the local level with some of the clients I have, they're actually doing their own internal studies and being prepared to report when anybody asks them, and they're providing the information. But they're actually taking action on the fact that some of these things don't make sense. We ran into a physician at one of my clients who would print it out, look at it, and then decided it didn't make sense to give it to the patient. And so he shredded it. I said, in front of the patient? But, you know, we found all kinds of sort of bizarre business processes that have been wrapped around the actual meaningful use criteria. And so I have some large clients who are actually being prepared to come in and present their own data results about what's been actionable, what's been helpful, and what really has been an exercise in order to check a box.
And not just a data issue, workflow issue.
Yeah, workflow, business process.
Oh my goodness.
Huge.
The National Quality Forum, they have a MAP initiative. It's pretty interesting. They've been floating some ideas around a data platform, not aggregated data, although some might move that way, but a platform that can be, and David Lansky's talked about it a lot. He's here in California, about ways that you don't hard code measures into your systems. And I know AAFP has been doing some work in that regard as well. We have a long way to go.
I'm going to take the moderator's prerogative, and I'm going to ask this question, and I'm going to really put it, California on the spot. What is it that the California, because we have a lot of experts, we have a lot of people doing this, what can California do to help the national direction and strategy? Is there something that we could be doing to help you get to your goals in what you guys are doing, Janet and Vicki?
Go ahead, Sarah. You can go.
And again, in the interest of time, I didn't go through this, but there has been such a rapid, large infusion of investment in all of these projects, literally since we're in 2012, in the last 3 years. And sharing lessons and taking a moment to pause and figure out how these pieces fit together. I was just talking to a colleague right before this presentation. There's a lot of really exciting work happening, whether it's the Direct Trust Project or the work that Dave Whitlinger, another no, he wasn't in California, New York, but he moved from the West Coast. The Beacons, the 360X initiative, there are all sorts of projects around both policy and standards. And I think well-meaning leaders across our country, hospital systems, vendors, and the like, I think folks, for the first time, you know, I heard it in our conference room 6 months ago and 2 months ago, are ready to come together and step forward on a set of common steps. And I think sort of taking stock of where we are and figuring out what's working, I think would benefit everyone. And hearing about your journey here in California would really help that process.
And the only thing I would add is I think all of us have been engaged in what I'm going to call a scientific experiment. We've all been
Yes.
scientists. We've been forming a hypothesis, saying what we think will work, and then testing those hypotheses. You all have done a tremendous amount of testing, and some things have worked, and some things haven't worked. And if we're really, truly scientists, we evaluate that, we make changes to our hypothesis, and we test again. I think you have that test bed here, and so it's really important that you collectively, in whatever groups or masses you can convene, make sure your story gets told. You know, I live in the middle of the country. So when you live in Tennessee, you look east, you look west, and you hope they never come into Tennessee. But, but a law professor once told me if I wanted to understand where I was going to go at some point in time, I better look west and I better look east. The country does look to see what California's doing, yes. And it really does matter to the country. And so I do think you would be remiss in your own experimentation not to make sure you're promoting not only your wins, but also what didn't work and what you did to adjust to that and whether the next iteration worked or not. So, you know, my call would be is that you all are scientists and just remember that and start publishing your experiments and what worked and what didn't.
Can I just say one more thing? Because if you look at who has invented things in our country that are new and innovative and solve problems, you know, a large percentage of them come from California. And I think we need some innovation and creativity, and in addition to sort of figuring out how the boxes work together and how to solve those problems. So we always look to the West Coast, often look to the West Coast for those things.
Thank you both. Would you all join me in thanking them for everything?